In this particular section, we are going to discuss on one of the most important and evergreen topics in pulmonology, that is COPD, chronic obstructive pulmonary disease. So, first question on you all will be, what do you mean by COPD? What is a COPD and what do you mean by a COPD? Whenever I ask this question to students, they go to the textbooks, they study the definitions of an emphysema, they study the definitions of a chronic bronchitis, and they come back to me and tell the next day that this is COPD, and which means it's an emphysema and a chronic bronchitis. And they will study the differences between chronic bronchitis and emphysema. They will tell pink puffers, blue bloaters, and all these things are fine. But what is basically a COPD? That's what the question is. So what defines a COPD? And how does bronchial asthma differ from a COPD? And why can't a bronchial asthma be a COPD? Why you can't put bronchial asthma under COPD diagnosis? Which means bronchial asthma is also going to have a chronicity, which means bronchial asthma, many patients start in the childhood and the disease runs throughout life in most of the patients. And they're also going to have obstructive lung disease. So why can't it be a chronic obstructive lung disease? And why you need two separate terminologies to define them? You have some reasons for that. First of all, what bridges the bronchial asthma and the chronic bronchitis and emphysema, all these things together, is the airflow limitation. That is what defines all these three things. So that's what binds all these three things together. But in general, let us see what do you mean by a COPD. So let us put the first basic thing. You tend to have airflow limitation. There's no doubt of that, which means you have obstruction in COPD, which is defined by your classic Tiffany-Pinelli index, FeV1 by FVC ratio of less than 0.7 or 70%. This is a must. You should have it. At the same time, you have certain additional features that define COPD. Like the obstruction tends to be fixed, and at the same time, it will be progressive. Many times you'll have a confusion of what do you mean by fixed. Fixed in the sense, the obstruction will not vary substantially during the attacks. At the same time, there will not be any much diurnal variation, which means obstruction tends to be fixed for a longer period of time. And the patient keeps smoking and obstruction increases over time. That is progressive. That is different. But it will not change within the day. It will not change that much between the attacks. So that's what I mean by no much variability, fixed obstruction. Plus, these patients are going to have an irreversible obstruction, which means by no means whatever you do, the PFT is not going to reverse back to normal. Finally, last but not the least, these patients will not have any bronchial hyperresponsiveness. No hyperresponsiveness to any allergens. This is what defines a COPD. And even though there are a lot of cases that overlap with COPD and bronchial asthma, but this is a classic definition and classic understanding of a COPD, and this is how it should behave, at least a classic variety of COPD. On the other hand, if you take a bronchial asthma, again, it's going to be defined by your classic airflow limitation, which is again defined by your Tiffany-Pinelli index of FeV1 by FVC ratio of less than 0.7 or 70%. Again, this is classic. But what differentiates a bronchial asthma from a COPD is the fact that the obstruction tends to be dynamic here. What do you mean by dynamic? Which means there is going to be a substantial variability between attacks. Means the first attack's PFR will be different. PFR means peak expiratory flow rate. And the second attack's PFR may be completely different. The PFR in the morning may be different and the PFR in the evening will be different. So there will be substantial variability and the entire disease is ultimately dynamic. It's going to change every time. It's not going to be the same. And by definition, bronchial asthma must be reversible, which means I'm not talking about the reversibility criteria you're going to give. The entire PFT, I'm telling it's reversible, which means the entire obstruction is reversible, which means bronchial asthma will have airway limitation or airflow limitation only during acute attacks, by definition. Only during attacks, they have airflow limitation, but otherwise, they don't have any airflow limitation at baseline. Whereas, that's what I mean by fixed here. the airflow limitation will be fixed at baseline as well. That is not a feature of bronchial asthma, at least theoretically and definition wise. Clear? And your entire idea of bronchial asthma is the fact that the bronchus is hyperresponsive. So here you will have this characteristic airway hyperresponsiveness, and you can prove this by a lot of methods. One of the best examples how you prove this bronchial hyperresponsiveness is by doing a methacholine challenge. That is why I have told this fact in PFT itself. If the methacholine challenge is negative, it completely rules out bronchial asthma. It is not possible. Positive, you don't know. It could be a bronchial asthma or it could not. But a negative methacholine challenge definitely rules out a bronchial asthma. It's not possible. This airway hyperresponsiveness is one of the must things in a bronchial asthma. There is absolutely no doubt about that. You have to clearly understand this fact. So these are the, first of all, the basic differences. How will you differentiate a COPD from a bronchial asthma? At the same time, there is something called a PFT normalization. Suppose if you encounter even a single normal PFT in between the attacks, 100% the diagnosis must be bronchial asthma. There is no doubt about that. It cannot be a COPD because PFT normalization is never going to happen in COPD because it's irreversible and it is fixed. By definition, at least it's not going to happen. 100%. But there are a lot of spectral overlap in that. There are a lot of patients with COPD who might behave like a bronchial asthma in some aspects. There are a lot of patients with bronchial asthma who might behave like a COPD in certain aspects, which we'll discuss again. That is called an asthma COPD overlap. But at least this is the classic differences between a COPD and asthma, where COPD tends to be fixed, no substantial variability between the attacks, irreversible obstruction, and they will never normalize the PFT at baseline, or which means they are never going to have normal PFT at any point in their lifetime from that point on. At the same time, there will be no bronchial hyperresponsiveness, whereas bronchial asthma is dynamic and the PFT is reversible, means many times it will normalize completely back to normal. Between the attacks, they will have a normal PFT. Only during the attack, they will show airflow limitation. And they will show substantial variability during the attacks. And finally, there is going to be bronchial hyperresponsiveness that defines bronchial asthma. But please do remember, there is overlap syndromes also, where there could be a COPD versus asthma overlap. Based on this understanding, COPD has two classic diseases. One you can put under emphysema, and second you can call it as chronic bronchitis. So is there really a need to differentiate these two disorders? Actually no, because both are going to behave in the same way, and both outcome is going to be the same way, and treatment of both is going to be the same way. But just for an undergrad pacifying fact, let me tell you what is this. Because the pathophysiology of these two disorders are different. Have you ever noticed the fact that chronic bronchitis is based on a clinical definition, whereas your emphysema is based on a pathological definition? Have you ever noticed this irony? What is the definition of a chronic bronchitis? Chronic bronchitis definition is nothing but you have a chronic productive cough. That's all. Which means you should have a cough with expectoration chronically. The definition of chronic here means you should have this productive cough at least for 3 months per year for 2 consecutive years. That's it. This is the definition of chronicity in chronic bronchitis definition. That's all. You should have a chronic productive cough, which means the productive cough should be there for at least 3 months each year for at least 2 consecutive years. So this is what we refer to as chronic bronchitis, which means a totally clinical definition. Any patient who fulfills this criteria clinically, or they tell this productive sputum for 2 years, 3 months a year, fine. That's a chronic bronchitis. That's it. But whereas emphysema is a pathological definition, which means emphysema means irreversible dilatation of air phase or air spaces distal to the terminal bronchiole. That's it. So which means, what is distal to the terminal bronchiole? Means the respiratory unit. Which means in emphysema, the problem is going to be in the respiratory unit. That's it. So it's an irreversible dilatation. That's all. That's the definition, which means it's a pathological definition. You all know that this emphysema is again divided into 3 types. One is called a centri-acinar emphysema, or otherwise referred to as a centri-lobular emphysema, or otherwise even referred to as a proximal acinar emphysema. All are the same. Then you have a pan-acinar emphysema, or a pan-lobular emphysema, or finally you have a distal acinar type, or otherwise called as paraseptal type, or otherwise even called as an irregular type of emphysema. So what is the basic difference between all these 3 things? It depends on where the problem happens. First of all, let us put a single respiratory bronchiole. This is a respiratory bronchiole coming from a terminal bronchiole, and it divides into multiple alveolar ducts. And each alveolar duct will have its own alveolar sacs, which have numerous alveoli. This respiratory bronchiole in turn comes from a terminal bronchiole. This terminal bronchiole is not going to give a different and lot of respiratory bronchiole. Not only this, just for simplistic purposes, I have made it a single respiratory bronchiole. Let us duplicate. So what really happens? Suppose if my airspace dilatation is affecting only the respiratory bronchiole, I am going to call it as a centri-acinar, centri-lobular, or a proximal acinar emphysema. Why it's called proximal acinar? Because this is the respiratory unit. So anything that's coming from the respiratory bronchiole is what we refer to as respiratory unit. And since it affects the proximal portion of the respiratory unit, it is also referred to as proximal acinar emphysema. But why it's called centri-lobular emphysema? Because you have this secondary pulmonary lobules we saw already in the basics, first lecture, where you have the pleural surface on the side like this. Here the problem will be in the center of the secondary pulmonary lobule, which means it's going to affect the central portion of the secondary pulmonary lobule. That's why it's called a centri-lobular emphysema as well. Okay. And what are the things that are important to understand in a centri-acinar type of emphysema? Centri-acinar emphysema is supposed to be the most common type of emphysema. 85 to 90% of the cases will be having this centri-acinar or centri-lobular type of emphysema only. It is the one that is associated with smoking, because smoking, due to unknown reasons, they have a very high attraction towards the respiratory bronchiole. They damage the respiratory bronchiole as much as possible. Even in chronic bronchitis, trust me, the most affected area is the respiratory bronchiole. But the change that is happening in chronic bronchitis is different, not this kind of dilatation. Third, it predominantly affects the upper lobe. Clear? So these are some of the important things that you have to note about this centri-acinar, centri-lobular type of emphysema. Whereas in pan-acinar type of emphysema, the entire respiratory unit will be affected and dilated. So whenever the entire respiratory unit is affected and dilated, that is what we call it as a pan-acinar or a pan-lobular emphysema. So what will be the area involved in a pan-acinar emphysema? Typically the entire respiratory lobule, secondary pulmonary lobule. The entire secondary pulmonary lobule will be dilated. So that is what we call the pan-acinar or a pan-lobular emphysema. Actually, it is less common and is usually associated with alpha-1 antitrypsin deficiency than smoking, and very commonly it is seen in the lower lobe. And next, you have this distal acinar or paraseptal type of emphysema, which means they are going to affect only the distal part of the acinus, the little bit of alveolar duct and the alveolar sac and alveoli. So which means since it's affecting only the distal portion, it's called a distal acinar type of emphysema. So if you want to show where the distal acinar emphysema will affect, typically they will affect the subpleural locations. They will be in the subpleural location, just below the pleura, in the periphery mostly, and little bit in the paraseptal regions as well, like this. So these are the typical areas of involvement in a paraseptal or a distal acinar type of emphysema. Remember, this paraseptal or distal acinar type of emphysema may coexist with your central acinar type and pan-acinar type. Sometimes they may coexist with them. And it is also believed that this distal acinar type is supposed to be the precursor for bulla formation. Is supposed to be the precursor for bulla formation also. This distal acinar type of emphysema is supposed to be the precursor for bulla formation. Clear? And very importantly, where this paraseptal emphysema location will be is in the dorsal portions of the upper lobe. Very common location of this paraseptal or distal acinar type of emphysema. Clear? So these are the three characteristic types of emphysema that you need to know. In image, you can see this is the respiratory bronchiole, what I am writing. And that is the only thing that is dilated in a centri acinar or a centri lobular type of a emphysema, where you can see in the secondary pulmonary lobule only the central portions are involved. Whereas in a pan-acinar type of emphysema, your entire respiratory unit is involved. And again, the secondary pulmonary lobule, the entire secondary pulmonary lobule is affected. You can see here. Similarly, this is a distal acinar type, where only the distal portions of the respiratory unit, that is the alveolar duct and alveolar sac, are predominantly involved. And in the CT also you can see only the subpleural locations are typically involved and the paraseptal locations are typically involved. Clear? So now, having seen about the definitions of chronic bronchitis, emphysema as well as asthma, you can deduce three things. Emphysema is a pathological definition. Chronic bronchitis is a clinical definition. Whereas your bronchial asthma is a PFT definition. You have to prove the bronchial hyperresponsiveness, you have to prove the reversibility, you have to prove the airway limitation is dynamic. So then only you can diagnose a bronchial asthma, which means bronchial asthma is a PFT definition and completely a PFT diagnosis, and your emphysema is a pathological definition, whereas chronic bronchitis is a clinical definition. But please trust me, none of these disorders can be diagnosed without a PFT. Which means to diagnose a bronchial asthma or a COPD, in the COPD, either an emphysema or a chronic bronchitis doesn't matter, you need a PFT to make a diagnosis. Because these are PFT based diagnoses. You can't diagnose clinically. These are PFT based because the basic definition is airflow limitation that binds all these things. Fine. Let us understand in a much better way. Even though this topic is a bit too much for you, but this will give you a lot of good understanding about the topic. Because I'm going to teach you something about asthma COPD overlap. So why I put 3 circles and 2 boxes? Sorry, 1 box. Let us assume this is a chronic bronchitis and this is an emphysema phenotype and this is a bronchial asthma phenotype. Clear? So that's what we're going to teach. First, you can see a lot of overlap is there between chronic bronchitis, emphysema and bronchial asthma. So what does this overlap mean? But you can also see what is this big box. This big box means this suggests airflow limitation. which means these are the patients who are going to have FE1 by FEC ratio of less than 0.7. The Tiffany-Pinelli index of less than 70%. Okay. And you can see certain subset of patients who don't have airflow limitation at all. These patients, you can see there is no airflow limitation whatsoever. They are located outside the box. But still, they can be emphysematous and they can be chronic bronchitis also, which means they meet the criteria for emphysema, which means the chest may be hyperinflated, the air spaces may be dilated, which means pathologically they meet the criteria for emphysema. And you have chronic bronchitis, which means clinically the definition of chronic bronchitis is met, but you don't have airflow limitation, which means even though this subset of patients, this group and this group, I'll again show you this group and this group, even though they meet the definitions of chronic bronchitis and emphysema, since they do not have airflow limitation, which is the basic criteria to diagnose a COPD, they will not be put under COPD. They cannot be called a COPD. Clear, it is not a COPD. You can tell emphysema, you can tell chronic bronchitis, but these people are not COPD because they don't have airflow limitation. But still these people have this hyperinflation, airspace dilation to tell emphysema, and still these people may produce a chronic sputum to tell it's a chronic bronchitis. Clear? Clear? So you can see again, a lot of patients have this particular overlap. Clear? So which means this red area which I have drawn, these are patients who's going to have a bronchial asthma along with the COPD. Phenotype that is similar to a bronchial asthma along with the COPD. What is the examples? Examples means, I told you bronchial asthma is characterized by airway hyperresponsiveness, which means in these patients, the airways will be hyperresponsive. Alright. Second, I told you they might show substantial reversibility. Remember, reversibility is different from PFT normalization. So what do you mean by reversibility? Reversibility, we have already defined. Reversibility means you give a bronchodilator and give post-bronchodilator test, spirometry. In the post-bronchodilator spirometry, if your FEV1 decreases by at least, FEV1 increases by at least 12% from the baseline, or if it increases by an absolute value of at least 200 ml from the baseline. So this is what we define as reversibility. And this also can be put under hyperresponsiveness, but anyways, fine. So they have bronchial hyperresponsiveness to call it a bronchial asthma. They have reversibility to an extent to call it as a bronchial asthma, but they won't have PFT normalization, which means they don't have normal PFT between the attacks, which is clearly telling the fact that these are not typical bronchial asthma cases. At the same time, they can have a chronic productive sputum. Chronic productive sputum, especially this group of patients, because they overlap with chronic bronchitis and bronchial asthma. So these patients may have chronic productive sputum. Previously, these patients were called as chronic asthmatic bronchitis. Chronic asthmatic bronchitis. How they can develop this COPD overlap? For example, let us assume a bronchial asthma patient who is chronically exposed to cigarette smoke or any other occupational exposure like dust, or because these are also one of the important things that can result in COPD. So bronchial asthma patient who's exposed to smoking or occupational exposure to a lot of dust may develop COPD later in life. So that is how these patients become a COPD and bronchial asthma overlap. Clear? So this will be the characteristic feature in those patients. Even though they show hyperresponsiveness and they show reversibility, but PFT will not normalize, which means it will be an irreversible defect. At the same time, they can have a chronic protective sputum, which is also telling the fact that these patients may have overlap with chronic bronchitis. So these are the example features that will tell you these are overlap patients with chronic bronchitis and emphysema and bronchial asthma. Okay, you can see that all these patients, and again I can put in different color, maybe in blue or green. So you can see these patients again are characteristically chronic bronchitis or emphysema. These are characteristically chronic bronchitis or emphysema. This group, and this group. These are characteristically chronic bronchitis emphysema. And you can see only this group of patients who are having airflow limitation because they come inside the rectangular box. These cases have airflow limitation. All these patients have airflow limitation, and they have some patients have an overlap with bronchial asthma, and these patients only should be called as COPD. And if they do not have airflow limitation, we are not going to call as COPD in the first place. That you have to know. Even in the presence of a definition of a chronic bronchitis or emphysema is fitting into the patient, they will not be called as COPD unless until they have airflow limitation. And similarly, you can see this subset of patients. These are typical bronchial asthma patients, but with airflow limitation. These are typically bronchial asthma patients with airflow limitation, which means they show all the characteristic features of reversibility, complete PFT reversibility. Only during acute attacks, they will have an obstructive PFT. At the same time, they will be showing typical bronchial hyperresponsiveness, and every single feature of bronchial asthma will be there, but they will have airflow limitation. So these are bronchial asthma patients. And the final subset of patients, you can see here, these patients are having bronchial asthma, but without airflow limitation. Which means they have that bronchial hyperresponsiveness. They have that, typical variability in the PEFR and all, but they have not yet progressed to develop a full-blown bronchial asthma, which means probably these patients could be early cases of bronchial asthma. So they have not yet progressed towards airflow limitation, because I told you this box is the one that defines the airflow limitation. So this is how you have to understand this asthma COPD overlap. So this is the current concept. So without airflow limitation, you can't diagnose a COPD. Clear? You can tell emphysema or you can tell chronic bronchitis, but you cannot tell it's a COPD. Point number one. Second, without that PFT normalization, you cannot call it's a bronchial asthma. You have to have a normal PFT. But remember, patient may have bronchial hyperresponsiveness even without airflow limitation. So in the early stage of bronchial asthma, these are some of the take-home points that you have to know from this particular diagram. So this is a very elegant and neat diagram, but even though it's complicated, it's very easy to understand. So now I think you will have a wholesome idea about how to diagnose a COPD and what do you mean by an emphysema, what do you mean by a bronchial asthma, what do you mean by a chronic bronchitis. At the same time, one important thing that tells it is emphysema for sure is the fact that they have reduced DLCO. Remember, none of these diseases apart from emphysema will have reduced DLCO. None of them will have reduced DLCO apart from emphysema. So these are some of the important facts. Even though I have not told the entire thing, but I have given an idea about how to go about these disorders. So this is called a Venn diagram, that is a very important one that it tells you all the diseases in a nutshell. So now with this background, let us discuss what is the differentiation between asthma and the COPD. This is given in each and every textbook. Let me explain you, because it's very trivial. Asthma, by definition, initial diagnosis will happen in children and teenage group. That is classically within 20 years mark. Whereas COPD is common after 40 years of age. That is in the second half of life. Whereas bronchial asthma will be diagnosed in the first half of life. Very typically, no doubt. And second, etiology wise, bronchial asthma has two types, allergic and non-allergic type. whereas COPD affects typically smokers. I come back to that point. COPD can happen in people who don't smoke also. Very important to understand, because it's taken for granted by many students and clinical practitioners that COPD never happens in a non-smoker. No, it's not like that. COPD can happen in a non-smoker. Let us see what are the causes of COPD in never smokers in some time. So, asthma in the sense non-allergic means asthma need not be only allergic. It can develop to dust exposure. It can develop to occupational allergens. It can develop to household dust, household smoke, pollution, outdoor pollution as well as indoor pollution. So all these things can predispose to asthma. So that is why we have a non-allergic variant of asthma also, which we'll discuss in the bronchial asthma section. Because we have an extrinsic and intrinsic type that is completely separate entity, we'll discuss in asthma section. Typically the attacks will be episodic. But in between the attacks, they will be completely symptom-free. Completely symptom-free, even without treatment. Very important point. Even without treatment, in between the attacks, they will be completely symptom-free, and the attacks are typically episodics and triggered by certain conditions that exacerbate. This is what hyperresponsiveness means. What are the conditions that exacerbate this asthma? Exercise, allergen exposure. Clear? So these are some things that increase the, or worsen or exacerbate the bronchial asthma. So this is what we call it as hyperresponsiveness. There will be something that triggers the, attack to come. Whereas here, I told you it is chronic, persistent, and progressive. It is never episodic. It's chronic, persistent, and progressive. We discussed this already. Lung function, remember, PFT wise, it is dynamic airflow limitation. Dynamic airflow limitation. Here it is persistent and fixed airflow limitation. Persistent and fixed airflow limitation. There is no change. Here it is absolutely dynamic. One of the very dynamic diseases you will encounter. So obstruction is completely reversible, which means it's a fully reversible obstruction, which means the PFT can completely normalize between the attacks. Here, it is an irreversible obstruction. The PFT will not normalize between the attacks, at least by definition. At the same time, even the responsiveness to different drugs will vary. One of the important differences in the drugs and the responses between a bronchial asthma and a COPD is the fact that the inflammation that is seen in a bronchial asthma is steroid responsive. They respond very, very, very well to steroids. Very important point. This is the entire basis of your GINA guidelines for bronchial asthma. They respond exceedingly and excellently well to steroids, especially the inhalational steroids. The inflammation in bronchial asthma is typically steroid responsive. Please note the point. Whereas in COPD, the inflammation is poorly steroid responsive. That is the reason if you take the guidelines and see in the step number 1 itself, you have inhaled the corticosteroids in case of a bronchial asthma, where you don't have corticosteroids even till 3 or 4 stage in case of a COPD. So steroids form a mainstay of treatment in bronchial asthma, but that's not the case in COPD because the inflammation seen is responding differently to steroids. At the same time, in COPD, they are more muscarinic antagonist responsive, which means they will respond more to this muscarinic antagonist like ipratropium or tiotropium. But here it is less responsive to muscarinic antagonists. That is the reason why in bronchial asthma guidelines you will not see much of a muscarinic antagonist like tiotropium or ipratropium. But whereas in COPD you will see a lot of tiotropium or ipratropium everywhere. LAMA, like SAMA, all these things will be a lot more used in COPD treatment rather than a bronchial asthma treatment. Typically, DLCO wise, DLCO is variable, but DLCO decrease typically goes towards emphysema. Remember, this is the only PFT finding that can concretely diagnose emphysema. There is no other PFT finding that can concretely diagnose emphysema because all the other factors can be seen in many other overlapping features. But remember, here the DLCO tends to be normal, or mild increase may be there during acute attacks, but who's going to do a DLCO during acute attacks? Rubbishness. So again, DLCO is normal in a chronic bronchitis. But remember, the moment DLCO is decreased, as I told you previously, the diagnosis must be emphysema and not anything else if you are dealing with an obstructive lung disease. Typically, the chest X-ray tends to be normal in case of bronchial asthma, whereas chest X-ray may show, I'm not telling always, chest X-ray may show hyperinflation in case of a COPD. So these are the basic differences. In this, the most important differences I want to substantiate once again, I want you to know very clearly is the fact that this is a dynamic, this is a persistent and fixed airflow limitation, reversible, irreversible. It means the PFT can completely reverse and normalize only in bronchial asthma. That's the gold standard for diagnosing bronchial asthma. It's not possible in the case of COPD. And finally, steroid responsive inflammation in case of bronchial asthma, whereas the inflammation that you see in COPD is poorly steroid responsive. Finally, the DLCO reduction is a typical feature of an emphysema. So these are the things I wanted you to substantiate. Remaining everything tends to be extremely trivial and you can remember very easily. So these are things you won't understand, and these are things that gives to a lot of importance in diagnosis of COPD and bronchial asthma. Let's move on to the pathophysiology of COPD. So what is going to be the pathophysiology of COPD? In the sense, like in this particular section, even though this is more theoretical, your lot of questions will be answered in this particular chart. Please pay attention on this. So first thing, you have a lot of environmental risk factors that happens in COPD. So the most important environmental risk factor, as far as everyone knows, is smoking. But please be clear in the fact that a lot of non-smokers also do get COPD. Typically, those who are exposed to indoor as well as outdoor pollution. So even though 80 to 90% of the COPD cases are due to smoking, there could be 10 to 20% of the cases which still could be happening in non-smokers. So there is an entity called COPD in never smokers. So please be aware of the fact. So smoking is the most common cause, but you can get in non-smokers. Almost 1 in 2 out of 10 may be non-smokers among COPD patients. Okay. So what this environmental factor is going to do is the fact that is going to induce an inflammation. So this inflammation is typically going to come from alveolar macrophages, which means these are macrophages that reside within the alveoli. You know that. And one important genetic risk factor is also there for getting a type of COPD called emphysema. That is nothing but alpha-1 antitrypsin deficiency. So first, let me clear about the alpha-1 antitrypsin deficiency part. So how it produces a emphysema. So you have your alveoli, you have capillaries, you have this basement membrane over here. And this capillary walls and alveolar walls are typically filled with something called elastin. Why? Because you need an elastic recoil and the lung should act like an elastic balloon. That's why. At the same time, you have a lot of elastases that are circulating in the blood as well. But these are very, very potential in damaging the elastic molecules in the lung, and they can destroy the elastin and they can, repair the elastic recoil mechanism of the lung. So to prevent that, you have a lot of antiproteases also in the form of alpha-1 antitrypsin. That is the thing that is going to neutralize and block the action of this elastases. Elastases are now normally generated by your inflammatory cells during their defense against microbes. So that is not something abnormal. But here, that's a normal tendency in the body to destroy the elastin, but still we have a counter mechanism to prevent that by producing anti-elastase molecules like alpha-1 antitrypsin. But the problem is in alpha-1 antitrypsin deficiency. For example, what happens? Your elastase and your alpha and antitrypsin should be in a balance. Let us assume these are elastase molecules and these are alpha and antitrypsin molecules. And both should be always in a balance with each other so that nothing overacts. But suppose in alpha and antitrypsin deficiency, if there is reduced amount of alpha and antitrypsin, your now elastases will become relative excess. I am not telling absolute excess. Elastases will be relatively high because alpha and antitrypsin is absolutely low. So that is the reason why you get emphysema. You result in destruction of the elastin fibers and you get emphysema. But you get a different kind of problem in a patient who is having environmental risk factor like smoking. So let us assume this is the alveolar macrophage and you do a smoking, and this smoking is going to trigger the alveolar macrophage and it's going to activate the alveolar macrophage, and this is going to produce a lot of substances like macrophage elastases, then inflammatory cytokines like interleukin 1, interleukin 6, TNF alpha, which are typical interleukins of macrophages, and they can produce matrix metalloproteinases also, and at the same time they can generate a lot of reactive oxygen species also. So you might ask a question, sir, then why not all smokers get COPD? That is because only certain people's macrophages go for this activation. Not all macrophages, all people's macrophages will go for activation. That is the idea. So only people who are susceptible will have this inflammatory effects. People who are not susceptible are not going to have this inflammatory effects. That is the reason why not all smokers develop COPD or emphysema. So now let us put the fact that only this inflammation will happen only in those who are susceptible to smoking and its effects or any environmental pollution and its effects. Obviously, I told you this inflammation by alveolar macrophages is going to activate elastases. They are going to produce in increased amounts. At the same time, they are going to increase the production of this matrix metalloproteinase also. All these are going to destroy your elastin and basement membrane. Now, this inflammation is also going to cause neutrophil activation and recruitment, and this also is going to produce, these neutrophils also are going to produce your neutrophil elastases and neutrophil matrix metalloproteinases. Already told you this elastases and your alpha and antitrypsin, that is antiproteases, should always be in a balance. But in this condition, there is increased elastases, but there can be a normal alpha and antitrypsin, there is no deficiency, but still increased elastases creates an imbalance, that is functional deficiency of alpha-1 antitrypsin. It is not in that much amount to compensate for that much amount of high elastasis that is present in these patients. But if you ask what happens in this alpha and antitrypsin deficiency, they also create an imbalance, but here it is absolute deficiency of alpha and antitrypsin, not excess of elastasis that's causing the problem. But anyways, both are causing an imbalance, and that's why elastases are working in excess. If elastases are going to work in excess, these elastases are going to destroy elastin, which means they are going to cause severe alveolar wall damage, because elastin is present in the alveolar walls only. As I told you, they are going to cause severe alveolar wall damage. At the same time, they are going to result in capillary damage as well. Clear? So this alveolar wall damage will typically result in loss of elastic recoil or reduced elastic recoil of this particular alveoli. So what is the importance of this elastic recoil? If you have an alveoli and you have damaged the wall and you have reduced elastic recoil, at the same time you have this capillary, and these capillaries are also destroyed. So what you generally do? So this alveoli now will become hyperinflated. So a lot of air will get trapped in this alveoli because they cannot do this elastic recoil, and they will produce the, they'll exhale the air out of the system. So there will be a lot of air trapping and hyperinflation. Remember, air trapping will increase residual volume is what we call air trapping, and increase total lung capacity is what we call hyperinflation. Both are consequences of loss of elastic recoil. At the same time, your capillaries are also damaged, resulting in reduced perfusion. Plus, at the same time, one more mechanism, the alveolar wall is typically damaged, which means whatever oxygen that is present in the alveoli cannot diffuse. So, what this loss of elastic recoil is going to do? It is going to produce air trapping, it is going to produce hyperinflation, and this air trapping and severe hyperinflation itself can reduce the vital capacity. How? How they can do that? Suppose let us assume these are the two alveoli. This is a normal one on the right side, and this is the hyperinflated alveoli on my left side. So remember, a normal alveoli, from the resting state, you inhale maximally and try to exhale as much as possible. That is what we call vital capacity. Maximum inhalation. From that point, how much ever you maximally exhale, that's what we call vital capacity. See this alveoli. So see the vital capacity of this alveoli and see this alveoli. It's already hyperinflated. And you think how much it can maximally expand? This much. And from this point, how much it can maximally exhale? How much have you tried? It must be this much because of loss of elastic recoil. It cannot fully recoil back. So maximal inhalation, maximal exhalation. So you can see what is the vital capacity here and what is the vital capacity here. So obviously this kind of hyperinflation and air trapping induced reduction in the vital capacity is what we refer to as something called a pseudo restriction, which we saw in the pulmonary function testing itself. At the same time, this air trapping and hyperinflation, apart from doing all this thing, because they are going to increase the residual volume, they are going to increase the total lung capacity, at the same time they are going to reduce the vital capacity as well. Apart from all these particular things, they are also going to produce reduced ventilation. Reduced ventilation. Clear? And again, because of the loss of elastic recoil, they also result in increased work of breathing. Because to expand this alveoli, again you need a lot of work, and to collapse this alveoli, again you have to do work, because you cannot collapse the alveoli. Because if you don't collapse the alveoli, you cannot inhale next time. Suppose if the alveoli ends at this point. Clear? Inspiration should be passive. Expiration should be passive. Why expiration is passive? Because of elastic recoil. These patients don't have elastic recoil. So expiration you have to do actively to bring the alveoli back to at least to some collapse stage. This is because the alveoli, suppose if you are inspiring, an alveoli becomes this point and it stays at that point. Next breath, how will you further expand the alveoli? So you will die. So to avoid that, to make a good ventilation, this patient has to constantly work always to collapse this alveoli to the resting state. So that is the reason why here the expiration also becomes not passive, in fact it's active here. So because of constant active expiration, the work of breathing is going to increase, and this is the reason why these patients are always dyspneic, which means they are dyspneic at rest. Always dyspneic at rest. And this excessive work of breathing and being dyspneic at rest is the main reason why these patients are extremely cachexic, which means they will be very, very thin built. They will not gain weight at all because they lose a lot of energy for breathing itself. And what are the effects of this capillary damage? This capillary damage effect is going to reduce the perfusion also. So you can see two things that are happening concurrently. One is loss of perfusion, at the same time loss of ventilation also, which means there is a relative VQ match instead of a mismatch. At least in the early stages. We are talking about the early stages of emphysema. They are having a VQ match, a good VQ match. This will prevent development of cyanosis. Clear? This will prevent the development of cyanosis, and that is the reason these patients are pink and they are not cyanosed at rest, and that's why they are called as pink puffers. Puffers because they are always hyperventilating because of excessive work of breathing. Pink because there is a good VQ match. Clear? So this is what is happening. At the same time, this alveolar wall damage will also prevent the oxygen from getting diffused into the capillaries. So this is also one reason why their DLCO will be low. So that is also the one reason why emphysema is a characteristic example of diffusion limitation. No other OLD has this feature, diffusion limitation. So I think now you can get it, all the points that you needed to know. Clear? So these are the things that are going to happen. At the same time, let us assume there are another group of susceptible patients who don't react with the macrophages. Instead, they react at the airway level itself, which means, let us come back to this image. Here, this smoking that is coming in is going to activate the macrophages. Let us assume there is another group of patients where macrophages are not reacting. Instead, the airways are reacting. Clear? Here, the airways are reactive. Here, the airways are reacting. How they are going to react? Through something called a squamous metaplasia. Squamous metaplasia that leads to increased thickness of the airways and smooth muscle hyperplasia and contraction. The bronchial smooth muscles, the bronchiolar smooth muscles will go for hyperplasia and contraction. And next thing, they will produce increased amount of goblet cells as a reaction, which produce excessive mucin. And this is the reason why these patients are going to produce productive cough, because of the mucin production. Clear? So this subset of patients who are reacting a little differently is going to behave in a different way. So now these patients are going to have airflow limitation because of reduction in airway caliber, because all these things will reduce the airway caliber and they are going to typically result in airflow limitation. Airflow limitation. Clear? So what is going to happen in these patients? Let us put a different alveoli, capillaries, basement membrane. Now all the problems happens in airways only. So this is, let us assume, smooth muscle proliferation along with mucus hypersecretion. They are producing a lot of mucus, excessive mucus hypersecretion in the airways, which means now you can see the air finds a difficult way to get in also, and it finds a difficult way to get out also. Air finds a difficult way to get in also, air finds a very, very difficult way to get out also. But whatever oxygen here, there is no diffusion limitation. Whatever it is here, that is fine. But carbon dioxide is moving out, but it's having a very poor way outside. It's not moving out properly. And oxygen also is not moving in properly, which means the carbon dioxide in the alveoli will increase and the oxygen in the alveoli will decrease. You know very well, this is a simple fact. You know the alveolar gas equation. The partial pressure of alveolar oxygen is equal to 713 into FaO2 minus PaCO2 by 0.8, which means the carbon dioxide, if it increases, naturally the alveolar oxygen will drop, which means the PaO2 is going to drop and the PaCO2 is going to increase. That is because of this typical drop in the ventilation. At the same time, they will have a normal perfusion, which means there is no damage to the capillary walls, alveolar walls or capillaries here. Which means these patients, since the oxygen diffusion, whatever is there, is normal, but the amount of oxygen entering itself is very less. So that is the reason, normal perfusion, reduced ventilation, they will go for a VQ mismatch. They'll go for a VQ mismatch. At the same time, DLCO will be normal. Why? Because there is no damage to the alveolar wall or the capillaries. So DLCO will be typically normal. So this airflow limitation will reduce the ventilation, but they will have a normal perfusion resulting in a VQ mismatch. This VQ mismatch will trigger hypoxemia at rest. Clear? And these patients will be having hypercarbia also. Hypercarbia at rest itself. And you know very well, this hypercarbia at rest is going to definitely go chronically. Once if it goes chronic, it's going to blunt the respiratory drive. It's going to further reduce respiratory drive. Remember, sudden hypercarbia may increase the respiratory drive, but chronic, slowly accumulating hypercarbia will blunt the respiratory drive and shift the threshold higher. That is the reason why these patients will have elevated PaCO2 at baseline itself, because of reduction in the respiratory drive. That is also the same reason why this patient will have hypoxemia at rest itself, reduced PaO2 at rest itself. And this hypoxemia, and again, since this is going to be chronic, they are going to be having one important problem, that is polycythemia. And again, this and all is extremely common with chronic bronchitis patients, polycythemia. Because they are having reduced respiratory drive, their work of breathing is actually quite less. That's why these patients are supposed to be stocky built, little bit obese, compared to the classic emphysema patients who are extremely thin built with very high work of breathing. I think you can understand here. So this is what is happening. At the same time, this chronic hypoxemia will activate the hypoxic pulmonary vasoconstriction. That is what we refer to as Euler-Liljestrand mechanism. We know that already. Because they activate the hypoxic pulmonary vasoconstriction, and even if it's going to be chronic, they are going to increase the mean pulmonary artery pressures, which means they are going to go for pulmonary hypertension, and typically they are going to go for corpulmonary. That is pulmonary hypertension induced right ventricular failure. And because of right ventricular failure and right heart failure, they'll go for edema. Because they are hypoxemic at rest, they also will be cyanosed. So that is the reason why they are called as blue and edematous bloaters. Clear? And two more interesting points. I told you, these patients will be hyperventilating. Increased work of breathing, somehow to maintain their life, they try to hyperventilate, and they are dyspneic at rest. And they are pink also, which means they will have a normal PaO2 at rest. But because they are dyspneic at rest, hyperventilating, they will have a low PaCO2 at rest. So what does this tell you? Normal PaO2 and a low PaCO2 at rest is a typical type 1 respiratory failure. Even though you might think like low PaO2 and low PaCO2 is a type 1 respiratory failure, no. Normal PaO2 with a low PaCO2 also is a compensated type 1 respiratory failure. Because here the patient is maintaining a normal PaO2 because of the hyperventilation only. That is not normal. Clear? Be very careful. So that's why emphysema is typically a type 1 respiratory failure at baseline. But these patients are going to have a low PaO2 at baseline, at the same time increased PaCO2 at baseline. That is why these patients typically suffer from type 2 respiratory failure at baseline itself. Fine. Now, since I told you these patients are typically having diffusion limitation, they will desaturate on exercise. So if they walk, if they do something, they desaturate on exercise. Clear? But these patients, if they exercise, obviously, you are going to produce a lot of sympathetic activity during exercise. So during exercise, sympathetics actually may increase the airway caliber. Airway caliber might increase. That is because of sympathetic action. Because the airway caliber increases, the ventilation will increase and they will improve the VQ mismatch. VQ mismatch might improve, and even PaO2 might increase because of the improved ventilation, because the airway caliber a little bit increases during exercise in these patients. Clear? And final nail in the coffin, I told you, these patients will have low perfusion. This is also one reason why the DLCO will be low. That is different. At the same time, because they have low perfusion, their chest X-ray or any radiological investigation, if you take, they will be hypovascular. And because they have little bronchoscopy markings, they go for bulla formation. And these hypovascular areas or avascular areas are the ones that form bulla. That is the reason why these emphysema patients are highly predisposed to development of bulla, and also they have a high risk of developing pneumothorax. But see these patients are having a relatively normal perfusion, isn't it? I told you there is no problem in the perfusion. So they have a relatively normal perfusion, or sometimes even increased perfusion, and that is the reason why they have increased bronchovascular markings. And that is also one reason bulla and pneumothorax are generally very rare in chronic bronchitis phenotype. Clear? At the same time, emphysema patients are prone for one more entity. Like I told you, they produce this inflammation. At the same time, they also try to generate a lot of reactive oxygen species. This can result in fibrosis. And that is also one reason emphysema patients will go for a lot of areas of fibrosis also. Chronically, if the ROS is very high, a lot of parenchymal destruction will happen and a lot of areas will go for fibrosis. That's why emphysema patients are prone for fibrosis, and because of that, restriction is possible in these patients. Clear? So this is the entire pathophysiology of COPD, and why you get a pink puff and why you get a blue bloater and why you have all these complications. So with this understanding of the pathophysiology, let us move on to the differences between emphysema and chronic bronchitis. Emphysema and chronic bronchitis. So emphysema is also called as type A COPD, and chronic bronchitis is also referred to as type B COPD. Typically, the lungs will be hyperinflated here, but in chronic bronchitis, it may be normal. Clear? Here, air trapping and hyperinflation is a typical feature of emphysema, but chronic bronchitis, you may or may not have hyperinflation. Typically, it may be normal. I told you these patients will be thin because of increased work of breathing, and these patients are going to be stocky because of low work of breathing, and they don't breathe at all. Because of chronic increase in PaCO2 will reduce blunt their respiratory drive. And these patients will be dyspneic at rest. These patients will not be dyspneic at rest. This patient will have increased work of breathing at rest, and these patients will have normal or decreased work of breathing at rest. These patients are going to have normal or decreased work of breathing at rest. And PaO2 at rest will be normal usually because of hyperventilation will normalize the PaO2. That's why they do that. And here PaO2 will be low at rest. Remember, but they will desaturate, which means the PaO2 will drop with exercise. This is due to diffusion limitation, which we have been discussing. But here, the PaO2 even may increase with exercise. That is due to increase in the airway caliber and improvement of the VQ mismatch. Which means at rest, these patients will have a normal VQ, which means it will be a VQ match. These patients at rest, they will have a VQ mismatch. And this is the reason these patients are pink, and this is the reason these patients are having cyanosis at rest, and this is the reason why these patients are blue. Clear? And what is the typical lung sound? Here is the wheeze, and that is due to dynamic airway compression. We have seen already this dynamic airway resistance and dynamic airway compression phenomenon in resistance and compliance section itself. Here you will develop rhonchi. That is not due to dynamic airway compression, that is due to airway resistance, airway limitation. Typically, remember, dynamic airway compression will produce wheeze only, which means if the airway is behaving dynamically, that will produce wheeze only because of progressive increase in the resistance. The airflow will keep changing, that will produce a multiple sounds like polyphonic wheeze. A fixed rhonchi is due to airflow limitation, and again at the same time rhonchi is developed, it's a snoring quality, and rhonchi will be developed because this mucus is hyper produced in this patient so that they splatter the mucus resulting in a rhonchi development. So all these things are very, very important. And chest X-ray will show hyperinflation plus reduced bronchovascular markings. At the same time, bulla is extremely common. Pneumothorax is also extremely common. Here, hyperinflation is rare. Bronchovascular markings may be increased or normal. Usually, bulla is rare. Pneumothorax is also rare. Pulmonary hypertension and resultant carpal nil are very, very rare in an emphysema, whereas it's extremely common in chronic bronchitis. And amyloidosis, very rare in an emphysema, but very common in chronic bronchitis. Finally, you know very well, these patients will be called as pink puffers, and this patient will be called as blue bloaters. Clear? So, what will be the respiratory failure type? I told you 3 things which you have discussed already. Let me tell you again. You have bronchial asthma, you have emphysema, and you have a chronic bronchitis. Remember at baseline how they behave, and what will happen when they go for acute exacerbation. Acute exacerbation. At baseline, remember, bronchial asthma patients will be completely normal. They won't have any problem. But emphysema patients behave like a type 1 respiratory failure and they'll be very dyspneic. Chronic bronchitis patients behave like a type 2 respiratory failure. Remember, during exacerbation, bronchial asthma patients will go for type 1 respiratory failure, and emphysema patients will be type 1 respiratory failure in early cases. In early cases, there will be severe type 1 respiratory failure, but in late stages, they'll go for type 2 respiratory failure. But bronchial asthma, chronic bronchitis patients typically again will become more severe type 2 respiratory failure patients. That's all. Remember, I told you bronchial asthma patients, if you do not treat in very severe, extremely severe or life-threatening bronchial asthma, which means the complete occlusion because of severe increase in the work of breathing, they may go for fatigue-induced type 2 respiratory failure. Remember, this is due to fatigue and exhaustion. Emphysema and chronic bronchitis patients going for type 2 respiratory failure is due to fatigue and exhaustion over time. So this is the entire pathophysiology I can tell in a nutshell in patients who are suffering from chronic bronchitis and emphysema as well as bronchial asthma. Clear? Audio number 80. Continue COPD part 3. After this, we have some more clinical features and investigations to diagnose in COPD. But before that, see one important index called as Reid index. That's an exam question, even though it's an autopsy finding, but still you have to note that for exam purposes. What you're going to do is you're going to check for the mucus gland thickness. This is the gland thickness that I marked in red, and here it's from B to C, so BC. And you're going to take that and compare that with this entire bronchial wall thickness. So this green color one is the bronchial wall thickness. So you're going to take a ratio of BC to AD ratio, and normally it should be less than 0.4, and this is the normal Reid index. If it's more than 0.4, that is highly suggestive of chronic bronchitis. Right. Apart from that, what are the clinical features? And always, please trust me, clinical findings and physical examination is unreliable for the diagnosis of COPD. This is the first thing that you have to note. It is completely unreliable for diagnosis of COPD because COPD is a PFT diagnosis. Very clearly. The patient may have emphysema, definition-wise they might have emphysema, and clinically they look like emphysema, and the patient may clinically have chronic bronchitis-like features. But I told you, only if you have this airflow limitation evidenced by Tiffany-Pinelli index ratio of less than 0.7, then only you can call those patients as COPD. So don't call these patients as COPD unless and until you do a PFT and confirm. You can call emphysema and chronic bronchitis, that's your wish clinically, but do not call them as COPD unless and until you do a PFT. So what are the findings you might see? You might see cough and sputum production, which is a feature of chronic bronchitis. And they can have dyspnea at rest, which is a feature of COPD. And they may have barrel-shaped chest, That is again a feature of emphysema. Distinct feature of emphysema. Barrel-shaped chest is also a feature of emphysema, where AP diameter will become more than the transverse diameter. But normally transverse must be more than the AB diameter of the chest. So they can have, apart from that, your reduced diaphragmatic excursion. You know, diaphragmatic excursion can be assessed by a clinical maneuver called tidal percussion. So this is how you find out the diaphragmatic excursion. And next thing, you might have something called a Hoover's sign. Positivity, again, it's a sign of emphysema. What do you mean by Hoover's sign? Hoover's sign means, first of all, you have to know what you mean by subcostal angle. So let us assume this is the abdomen and this is the chest, and the angle between these two subcostal regions is what we refer to as subcostal angle. And normally the subcostal angle tends to increase with inspiration, but if it paradoxically decreases with inspiration, that is what we refer to as something called a costal paradox, or otherwise referred to as Hoover's sign. That is seen in emphysema again, typically seen in emphysema. And you can also note hyperresonant note on percussion. So all these are typical features of emphysema than chronic bronchitis in physical examination. So this will be a feature of chronic bronchitis than emphysema on clinical examination. Clear? So these are the important clinical features that you have to know. But remember, clinical features are completely underlabel. So then coming to the investigations. Investigations wise, the most important investigation, single most important, is the PFT, pulmonary function test, that you have to do, where characteristically you will see the FEV1 by FVC ratio to be less than 0.7. This is the most important one, Tiffany Pinelli index, obstructive spirometry. FE1 definitely will be decreased, FVC variable, typically normal in a chronic bronchitis, whereas it can be normal or decreased in a emphysema. It depends. And your residual volume typically increased, total lung capacity typically increased, and again your DLCO will be variable. Remember, it is normal in case of a chronic bronchitis, whereas it will be decreased in case of a emphysema. There is no doubt about that. These are the typical spirometry findings that you're going to get. Then in PFT, you have to do the reversibility testing also. Remember, this name reversibility itself is controversial because we are not assessing reversibility of PFT, we are assessing the reversibility of FEV1. So what you are assessing is going to be important. Remember, in COPD, no matter what you do, PFT will never normalize. PFT never will normalize, no matter what. If it normalizes, then the diagnosis is bronchial asthma. PFT never normalizes in a COPD. FE1 by FVC ratio will always be less than 0.7 only. That is the definition of COPD. Never normalizes and always it remains the same. That is less than 0.7. Irrespective of whether you do bronchodilator or steroid, whatever you do. If you give a bronchodilator, you know very well the PFT never normalizes. But you have to assess reversibility, and again it is irreversible. Even the FE1 is going to be irreversible, which means it is not going to show the typical changes. For example, the FE1 increase after bronchodilator will be less than 12%, and increase in absolute value by less than 200 ml. Again, this is poorly reversible. Still, some reversibility will still be there, but it is very poorly reversible. Bronchial asthma, on the other hand, will show reversibility by more than 12% and more than 200 ml. So these are very important facts again. So then imaging. Imaging again is not sensitive or specific. PFT is the gold standard. Imaging is not required for diagnosis. You don't need this imaging for diagnosis of COPD in the first place. PFT is the key. Again, how much ever times I tell, it doesn't change. PFT is the key. Okay. Probably in a chest X-ray, what all you can find? In a chest X-ray, you can see this barrel-shaped chest, and you can see this widened intercostal spaces. That is because of hyperinflation of the lung, and these are typical changes of emphysema. And increased AP diameter you can see in the lateral radiographs, and diaphragmatic flattening will be there. That is because of hyperinflation of the lungs. and there will be hyperlucency of the lung. So these are the typical chest X-ray findings. So let us see chest X-ray findings, some of the chest X-ray findings. What are the things you are seeing is the flattening of the diaphragm. This is what you are seeing. Let me put different color maybe. So this is the characteristic diaphragmatic flattening. So that's the flattening of the diaphragm you are seeing. At the same time, you can see this typical hyperinflation. Typical hyperlucency that is suggestive of hyperinflation. So this is definitely a COPD, no doubt. And here what you are seeing is this definite bulla here. You can see such a thin one with severe hyperlucency. This is a bulla over here. It's a large upper lobe bulla here. And this pink arrows are showing fibrosis. I told you, emphysema is highly prone for fibrosis again. You can get fibrosis. A lot of fibrotic areas. That is because of ROs and you're damaged by inflammatory cytokines. I told you. And typically you get fibrosis in emphysema. Okay. Next is the ABG. Do you need an ABG? In a COPD patient, there are two indications for ABG. Number one, very commonly you do it in acute exacerbation. Second, to assess the need for LTOT. Assess the need for long-term oxygen therapy. So these are the areas where you need ABG. Otherwise, outside these areas, ABG is definitely not a very important and essential investigation. So to assess the need for LTOT and what is the indications for giving a long-term oxygen therapy, that is LTOT, we'll discuss in some time. But at the same time, this acute exacerbation, I told you why you need this thing to differentiate between a type 1 and type 2 respiratory failure. You need this ABG. But apart from that, ABG is not routinely needed for diagnosis of COPD in the first place. With this, I think we can finish off this particular section of the video. In the next section, we might move on to the treatment of COPD, which itself needs a lot of discussion.